Okay, so now we are going to see physical examination and okay. So in physical examination, first we look at the general appearance of the patient. Like when we enter the room, we need to know how the patient is doing. So because of ascites, mostly because of the increased abdominal pressure, the patient can look uncomfortable. And again, because of malnutrition and underlying malignancy, there can be cachexia too. And if there is hepatic encephalopathy, the patient can look confused. So once we have seen the general appearance, we go for the vitals. So in vitals, there can be hypotension and tachycardia, and temperature can be febrile if there is hepatitis or if there is any malignancy, and oxygen saturation can be reduced. Um, it can be seen as hypoxia, and that can be tachypnea. From what I understood, uh, is that the hypoxia and tachypnea are mostly due to the increased abdominal pressure, which tampers with the breathing. And but please let me know if there is any other mechanism that is involved resulting in hypoxia in patients with ascites. And then we check the head, neck, and throat. So in the eyes, there will be icterus and pallor. And if there is alcoholic liver disease, then there can be parotid hypertrophy. And then hepaticus, which is a characteristic order seen in patients with alcoholic liver disease. And elevated JVP if there is portal hypertension. And then temporal wasting, which I believe from what I have been able to read and gather is due to muscle depletion, either caused due to malnutrition associated with alcoholic liver disease, or because of any underlying malignancy. However, please let me know if there is any other mechanism involved specifically in temporal wasting. And if there in rare conditions when there is an autoimmune disease, it can result in oral ulcers um, because of the inflammatory processes. And then we examine the chest. Spider angioma. So a tip here is that spider angiomas are usually seen above the level of umbilicus, and it is not seen below. And then gynecomastia, and then squaring of shoulders. Again, squaring of shoulders is mainly because of muscle depletion that is seen alongside with this. And then, I'm sorry. And then there can be decreased hair seen in axilla and chest. So these are some of the things that you can see in the chest region. And then on percussion. So on percussion, um, there can be decreased dullness if there is associated pleural effusion. So there is not much of palpation here in the chest region when it comes to ascites examination. And then auscultation. So in auscultation, if there is pulmonary edema again associated with heart failure, then there can be decreased in air entry. And then again, another due to the rare condition where there is a connective tissue disorder, it can lead to pericarditis, which can be seen with a frictional rub. And then I also came across this point where we can listen to a venous hum in the chest region. Um, I will be covering about this again when we go through the abdominal examination, and I have a question there if for clarification as well. And then, um, so this is regarding the chest examination, and now we're going to examine the abdomen. Okay, so now we're going to see how to examine the abdomen. Okay, so again, we start with inspection. So in inspection, first thing to notice will be the ascites, the abdomen. So the abdomen will be distended. Okay, and then other signs of advanced liver disease or cirrhosis, for example, caput medusae because of dilated veins due to portal hypertension. And then if there is any hemorrhage, then we can see Cullen sign. So Cullen sign is basically in the umbilicus, and Gray Turner sign uh, is near the flanks. So these both are for hemorrhage. And then if there is any underlying malignancy, then there can be a metastatic nodule called Systemaire Joseph nodule in the umbilicus. And then in the genital region, there can be decreased pubic hair and testicular atrophy. So these are the things that we can see in inspection. And then we do percussion and palpation together in abdomen, because most of the examinations would require both the techniques. So first, again, when we touch, there can be tenderness, and there can be rigidity and guarding. After that, we are going to examine the ascites itself. So um, because of the fluid collection, there can be shifting dullness and flank dullness. Okay, and we also are aware of another test where we test the fluid wave, but certain sources say that it is not recommended to do the fluid wave any longer, because it's either because it's unreliable and it often requires two people. Okay, and then we examine the liver. So we check the span, and then the edges, then surface, and we also look for any nodes. And then we look for the spleen to see if there is any splenomegaly. So how do we check splenomegaly? There are three different techniques or methods that we can see. So one is using the Trop space, and then another one is Castle sign, and another method is Nixon's method. So let's just go briefly about what these techniques are. So Trop space is basically it's like a semicircle, not semicircular, it's like a crescent shape or a triangular shape, you can say. So the base of the sixth costal margin, and then the left costal margin, and the anterior mid axillary line, the base of the sixth rib. So this is Straub space, and it should be usually resonant, but if on full inspiration, if it is dull on full inspiration, then it is probable that there is a splenomegaly. And Castle sign is basically looking at the last intercostal space, percussing there, like probably here, which is usually the eighth or ninth intercostal space. And it should be resonant on inspiration, full inspiration. But if it is dull, then possibly there is splenomegaly. And Nixon's method, we ask the patient to lie in the right lateral decubitus position, and again we take the left costal margin, we take the midpoint and then we percuss upwards perpendicular to the left costal margin. And if the dullness is present for more than 8 centimeters, then it is possible that there is splenomegaly. So these are some of the signs, some of the methods that we can use to examine the spleen. And then finally there is also so we saw about liver, then spleen, and then about any other swelling. So, and one thing that we will also have to look for is Covice's sign. So it is basically painless if there is palpable gallbladder associated with painless jaundice, that means that can be an underlying malignancy in that region. So this is Covice's sign. So these are some of the things that we will be looking for in percussion or palpation. And then finally, auscultation. In auscultation, this is where I wanted your insight as well. So there is a sign called as if I'm pronouncing it correctly, Corwelier Baumgarten syndrome. I believe I'm spelling it correctly. Crevelier, I'm sorry. So this is Crevelier. Crevelier Baumgarten syndrome. So what I was able to find out is that in some patients, when there is a patent umbilical vein, and then when there is associated portal hypertension, we can hear a loud venous hum, and that is called as Cavalier Baumgarten murmur, and which it is usually heard in the upper abdomen. What I would like to know is if this is the same venous hum that we hear in the this one here. Is it the same venous hum that we hear in the chest region, or is it different, or is there any other mechanism involved in this finding where we are able to listen to a venous hum in the chest? Okay, so I believe this is all about the abdominal examination, and then we have the extremities. So let me go to that. So here again in hand there are some signs that we can look for. So one is Terry's nails. So Terry's nails is when the lunula in the nail, which is usually on the white patch here. Whereas in patients with advanced liver disease, it can be pushed up with just one thin red band at the top. So this is called as Terry's nail. And then we can also see leukonychia, where there are white spots or white stripes in the nails. And then there can be palmar erythema. Just give me a minute. Okay. There can be palmar erythema. So what we need to remember here is that in palmar erythema, it is usually seen. Please excuse my drawing. Okay, this is the thumb. Okay, so it is usually seen in the hypothenar eminence, but it can also be seen in the thenar eminence. But the hypothenar eminence, it's the most prominent or most common one, and then the thenar eminence, and usually the center area is paired. And then we can also look for Dupuytren's contracture. So what happens here is there is thickening of the palmar skin along with the skin in near the base of the fingers. So because of this thickening, it will pull the fingers towards the center, and that is called as Dupuytren's contracture. And then asterixis. Asterixis is an involuntary movement in the hand, is usually again seen in advanced liver disease. We also call this flapping tremor, where you extend the hand, and then when you release it, the person will have tremors in case in a, like flapping their hands. Okay. And then in lower limb, what are the findings that we can look for? uh, we can see ankle edema, if there is associated congestive heart failure or even in severe portal hypertension. And then cyanosis everywhere, I mean peripheral cyanosis, um, again seen in case of congestive heart failure. And then we can also see jaundice, and then even because of decompensated liver, there can be bruising or petechiae seen seen everywhere. And again, on rare occasions, if there is an autoimmune condition associated with it, then we can also see arthritis and digital ulcers. Okay, so this is about the physical examination. So let's go briefly about it. And so first, we walk in and we see the general appearance of the patient. The patient can be uncomfortable, cachectic because of either malnutrition or malignancy. And then if there is hepatic encephalopathy, the patient can also look confused. And then we look for the vitals. There can be decreased blood pressure and tachycardia, and the patient can be febrile, and there can also be hypoxia and tachypnea, probably because of increased abdominal pressure associated with ascites. However, please let me know if there is any other mechanism that can be involved. And then we check the head, neck and throat. So there can be scleral icterus in the eyes and pallor, and if there is alcoholic liver disease, there can be parotid hypertrophy. Then feta hepaticus, which is a characteristic breath that is seen in patients with advanced liver disease or alcoholic liver disease mainly. um and please let me know if it is seen in other types of liver disease as well. And then there can be elevated JVP in case of portal hypertension, and there can be temporal wasting, and that is because of muscle depletion, seen either with malnutrition or with malignancy. But again, please let me know if there is another mechanism involved here. And in rare occasions, when there is an autoimmune condition, there can be oral ulcers as well. And then we examine the chest. So first we start with inspection. So there can be spider angioma, and spider angioma are almost always seen above the level of umbilicus. And there can be gynecomastia, squaring of shoulders, again because of muscle depletion, and decrease in hair in axilla and chest. And then on percussion, we can see dullness. I'm sorry, there can be dullness, not decrease in dullness. There can be dullness on percussion. That is probably because of pleural effusion. And then on auscultation, there can be decreased air entry if there is pulmonary edema. And if there is an autoimmune condition, it can lead to pericarditis, which can result in a frictional rub. And we can also listen to a venous hum. But please let me know if it is different from the mechanism that is involved in Curvelier-Bermer-Gardin syndrome. And then we examine the abdomen. So in abdomen, on inspection, we see the abdomen is distended, and there can be caput medusa because of dilated veins. And I will highlight things in purple, which are, I feel like, an interesting term for us to remember. The Cullen sign is when there is, it is seen when there is peritoneal hemorrhage, and it is usually seen around the umbilicus. And gray Turner sign is when you see the bruising in the flanks. This is again because of hemorrhage. And then systematic Joseph nodules, or the ones, or the metastatic nodules seen in the umbilicus, which can indicate that there is an underlying malignancy. And decreased pubic hair and testicular atrophy that can be seen in the genital region. And then in percussion and palpation, so first, when we touch the patient, we need to make sure that the patient is not tender. Is not having any tenderness or rigidity or guarding. That means that the patient is in severe pain, so we need to be careful about how we proceed with the examination. And then we check the ascites. Because of the fluid collection, there will be shifting dullness and frank dullness. And then we check the liver, we check the span first, and we also see how the edges are and how the surface is, and if there are any nodules present. And then we go for spleen. So in spleen, again, there are three methods. So one is by checking the trough space, so the sixth costal rib and and then the left costal margin on the left, and anterior mid-axillary line on the right. And I said it in the opposite direction. So on the left we have the mid-axillary line, anterior mid-axillary line, and then on the right we have the left costal margin, and on superiorly we have the sixth costal rib, and it is usually resonant on full inspiration. But if it is dull on full inspiration, then there is probably there is a splenomegaly. And then Castle sign, we look at the last intercostal space, which is usually 8th or 9th. And then Nixon's method, for this we ask the patient to lie. The other two, Traub's and Castle, the patient should be on supine position, whereas Nixon's method, the patient will be lying on the right lateral decubitus position. And of course, finally, Courvoisier's sign, where we can palpate the gallbladder, and it can be associated with painless jaundice. That means there is an underlying malignancy over there. And then on auscultation, which we discussed about it again, Creuelia-Baumgarten syndrome, which is because of patent umbilical vein, and it can result in a loud venous hum seen in the upper abdomen. And then we look at the extremities. So first is hand, we look for teres nails, and then leukonychia, palmar erythema, usually seen on the hypothenar eminence, Dupuytren's contracture, and asterexis. In the lower limb, we can look for ankle edema, and then peripheral cyanosis in both the limbs. And then we can look for jaundice and bruising and petechiae because of decompensated liver, and then arthritis and digital ulcers in case of autoimmune conditions. So this is briefly about the physical examination that we do on ascites. Next, we can see how to do the investigation.